checkpoint inhibitors, metastatic non-small cell lung cancer, that being the topic. So start with my disclosures. And I also had some disclaimer. I am part of the converted with regards to the role of immunotherapy. I used to think that these class of agents may not fit in this treatment of cancer, but now I believe it. And I have personally taken care of patients who witnessed extremely good responses and durable responses with immune checkpoint inhibitors. But having said that, the question here is, are we curing metastatic non-small cell lung cancer? And George was here with a serious face telling us that he is curing patients. Seriously? Now, I was thinking, why might George come and do this? Perhaps he was watching a lot of these commercials on TV about immune checkpoint inhibitors. But then, no, that couldn't be the reason why he said all these things. I think the real reason is he's watching too many MD Anderson commercials on TV. They are making cancer history. So that's why he's coming and telling us that it's and they are the official cancer center of the PGA Tour, in case you didn't know. So I did go and look at the Merriam-Webster dictionary for definition of cure. And these are some of the definitions: something that stops a disease, makes someone healthy again, something that ends a problem or improves a bad situation, or the act of making someone healthy after an illness. I did not see any data that George showed that would fit in with any of these definitions so far. But let's move forward. Let's look at curable settings in non-small cell lung cancer and what they look like. These are some of the settings where we've achieved cures in recent years. One is in early stage lung cancer. When you add chemotherapy, now surgery cures a subset of patients. When you add chemotherapy, we have modest improvements in cure rates. In stage 3 disease, we have cure rates in approximately 20% of the patients who receive combined chemotherapy and radiation. And in limited stage small cell lung cancer as well, with combined modality therapy, cures are seen in about 25% of the patients. If you look at the trials that showed these cures, these are the main studies. In the early stage, I brought the example of the IALT and the NCI Canada trial. And if you look at the median follow-up on these trials is about 5 years. In the RTOG 9410 trial, the median follow-up for the 28 patients that were alive was 11 years. And in the small cell intergroup trial that showed that giving radiation twice a day to the chest improved survival, the median follow-up was 8 years. So now let's go back and look at what's the median follow-up on the trials that George showed us that are curing patients with metastatic non-small cell lung cancer. This is the Nivo versus docetaxel squamous cell lung cancer trial. This curve is taken from the package insert, and the median follow-up on the manuscript is a minimum of 11 months. That's the median follow-up that they have. Now, you may say that these patients have a tail, it's going to look good, but look at this part of the curve. There is a tail here, but what happened to that tail a few months later? Even the tail is dropping off. And then, if you believe the tail is true, even docetaxel has a trail. So, are we curing patients with docetaxel? Look at the number of patients at risk here towards the tail. We're talking very small numbers, 5, 7 patients with limited follow-up. What about the non-squamous trial? This again shows you the median follow-up or minimum follow-up as they reported in the publication is only about 13 months. And here again, we have not started seeing a tail yet, and both of these are going down. Now, this is a trial I had the privilege of being one of the co-PIs. This is the phase 2 study in squamous cell lung cancer with nivolumab. And here, when we initially reported the results, the 1-year survival was 40%. And our feeling was those who were bad actors or already came off study, and the patients who benefited are the ones who are going to benefit for a longer length of time. Leora Hahn updated this in World Conference on Lung Cancer, and we already saw that the survival at 18 months had come down to 27%. So the longer the follow-up, you are going to see these patients have disease progression. So we don't want to jump into conclusions too early. This guy is looking for something, and this is what he sees when he looks at the shadow, but really what waits is something very different. So we got to be careful about making conclusions when the follow-up information is limited. Now, definition of cure in cancer conventionally, what do we think as oncologists and what has the oncology community seen, is that you maintain a state of complete remission for 5 years. So in other words, you cannot make cancer history if the cancer is still there in the patient. So let's look at what's the complete response rate in all of these trials. This is the Nivo versus Opdivo or docetaxel non-squamous trial, and the complete response rate is 1.4%. In other words, even the best responders, they still have the tumor. Only 1% of the patients had no tumor left during the time these patients were followed up. What about pembrolizumab? This is also from the package insert. These are patients with the highest membrane score, greater than 50% positivity, the best responders in the pembro database, and the complete response rate is 0%. Not a single patient achieved complete response with this. Now, George might say, well, we have the Nivo EP or the CTLA-4 PD-1 combined blockade that can cure patients. Well, here is the complete response rate. In the same slide that George showed is 0%. Now, in melanoma, it's a little different. 20% complete response rate is seen with this combination. That makes you think perhaps there is a subset there that might be cured with this combination. But based on these data in lung cancer, it's hard to believe that we're going to cure patients with this combination approach. So what's really happening here is we have an exciting group of drugs that are early in their development cycle. So this is the conventional drug cycle. When a drug is developed, the technology triggers a lot of excitement, the initial results, media hype, physician excitement, and then it hits a peak. And then once you pass the peak of expectations, you go through the trough of disillusionment. And you can see all kinds of things happening here. And then finally comes the slope of enlightenment when people really figure out, oh, there's a biomarker, this is what's happening. Then we start going to a plateau state where we know who to use it, what's the best to expect, and so forth. So we are at this point, somewhere around this point with immune checkpoint inhibitors. Now, just remember the shape of this curve, and there are some parallels here. So, no, I can go back if people want to look at it, but I figured it's pretty much self-explanatory. So while the checkpoint inhibitors are new and we're blocking the PD-1, PD-L1, or CTLA-4 pathways, we've had a number of treatment modalities in our hands that affect the immune system in a number of ways that's been known well before the immune checkpoint inhibitors became available. So if you look at radiotherapy, it increases lymphocyte infiltration into the tumor, it induces immunogenic cell death. If you look at chemotherapy again, it works on various aspects of what we consider hallmarks for mechanisms of synergy in immunotherapy. And more focused, when you just look at various chemotherapy agents, we've known that they have a variety of effects on the immune system. So for example, gemcitabine has an effect on suppressing the myeloid-derived suppressor cells. Tyrosine kinase inhibitors have effect on various immune activators. So a lot of these drugs have been around which have various functions, and we still haven't cured anybody with any of these agents. Now, obviously, developing combinations will get us better clinical outcomes, but will that translate into cure? At this point, remains more hopeful and promising strategy. I wouldn't get too negative on this. I think we have a lot to learn and go farther. But let's start with early stage disease, where the patients have had a CR after surgery, and see what happens with the use of immune checkpoint inhibitors. This is what Jamie showed, the Alchemist trial. The third arm in the Alchemist that will be soon added will compare nivolumab to observation in patients with surgically resected lung cancer after they have received chemotherapy. So this would be a good start to see if we can cure patients in this setting. Then perhaps that gives us the basis to believe that additional strategies will lead to more cures. So we're at a point where we all want to believe that immune checkpoint inhibitors cure metastatic non-small cell lung cancer, but at least logic and history show us opposite signs. So I want to conclude by saying that despite the exciting results, there is no evidence that a single patient has been cured with checkpoint inhibitors. Well, if checkpoint inhibitors don't cure patients, what really cures patients? I do have a cure. Thank you.